Hello, my name is David James, and I work in the Department of Interprofessional Practice and Training. I'd like to share with you guys an exemplar of evidence-based practice, and we're going to use mobility as our exemplar for practice. So a little bit about our road trip today. I want to share with you about my journey as a clinician, an educator, EBP, and QI. And I want to share with you our IHI age-friendly initiative, specifically the 4M's framework and how mobility can be thought of as an exemplar for evidence-based practice, and then help you think about evidence-based practice and the gaps you see in your current clinical practice and how you might use those to think about your future residency project. So let's start a little bit about today's frame. So this is one of my favorite quotes, is that all improvement is change, but not all change is improvement. So I've been at UAB for a number of years, and I can tell you that sometimes we make changes that are really not improvements. So our challenge is to make sure we're advocating for changes that truly are value added, both to the patients, the families, and our fellow healthcare professionals. So a little bit about my journey. I graduated in 1998 from UAB with my BSN in nursing. I was hired on the pulmonary unit, which at that time was in Jefferson Tower. And I was served as a staff nurse and a preceptor on the pulmonary unit. I wasn't really sure what I wanted to do. Some of my friends were in the MIC, which at the time was on Quarterback Tower. And I was like, I don't know, I kind of want to do that, I don't know. But I did go ahead and start the teaching certificate program at UAB because I wasn't sure what my graduate journey was going to be, but I knew I could use the information in the certificate in my role as a preceptor and teaching patients and their families. I transitioned to MICU as a staff RN and was eventually a leave charge nurse there. And I finished up my graduate clinical nurse specialist degree at that time. I was one of the very few CNSs in our program, but I really did like the role of the CNS as an advocate and intermediary between nursing and medicine and implementing evidence-based practice for populations. I started as a CNS in the MICU for a number of years. And at that time, I also started teaching at the School of Nursing as an instructor for undergraduate foundations courses. At the time in MICU, we transitioned from a 12-bed unit to a 25-bed unit where they are currently. And at that time, we hired over 100 RNs in 1 year. So I kind of got an insight into what orientational morning might look like. And with that experience, then I transitioned to the Center for Nursing Excellence, where I finished my doctorate of nursing practice and really worked with our onboarding program, a residency program, and other programs within the center. At that time, I transitioned to teaching graduate courses at the School of Nursing and was like really interested in QI. I had a lot of background in education. I got some QI in my DNP program. So I worked on and completed the Master's of Science in Healthcare Quality and Safety. And with that, I transitioned to our current role, the Department of Professional Practice and Training, where I work with our mobility program and other programs for vulnerable patients. So I share all this with you to show you that there are many paths. I know sometimes students are like, I'm going to be a nurse practitioner, so what we're going to do, and that's fine. That's completely appropriate, but there are many paths, and I would encourage you to just reflect on what is your interest and your passion, and how can you create a career trajectory that uses that interest and passion, and that would be my advice. I'm happy to share more about that or just reach out to you. But today we're focusing on evidence-based practice. So what is evidence-based practice? Well, evidence-based practice is really addressing a gap. So you have to think about what is the practice gap you're trying to address? What is the thing that's driving you batty about when you go to work? What is the thing we're not doing that we should be doing? So we can think about variability in practice. We can think about new practices we need to do. So for my practice, the silver tsunami is our practice gap. So we think about this aging population. We think about these vulnerable older adults who are coming into the hospital for care. And how do we take care of that? So the silver tsunami is that idea that baby boomers are aging, and as they age, they require more health care. So the practice gap that I'm focused on is caring for these vulnerable adults. And so when we think about vulnerable adults, it really isn't just age. It's really about who can tolerate usual health care and who cannot. So patients that are functionally and cognitively intact have plenty of room to spare. It really doesn't matter what we do or don't do in the hospital, they're going to be all right. What we're worried about are those patients who are functionally or cognitively impaired. They really don't have much resilience or wiggle room when it comes to care, and it doesn't take but a few hiccups during their hospitalization to be a major setback for them. A scary statistic that we think about for our older adults is that a third of patients over 70 and over half of patients over 85 will leave the hospital more disabled when they arrive. So just think about that for a moment. You come in the hospital to get better, yet you leave more disabled. So how do we address that? That could be our practice gap. So how do we do that? So the IHI provides a framework for caring for vulnerable adults, older geriatric patients. And it uses the 4M's framework. What matters? How do we align our care with the goals and the values of the patients and families? Mobility, how do we provide safe mobility every day? Mentation, how do we address the 3Ds, delirium, dementia, depression, and medications? How do we ensure the medications we give do not interfere with what matters, mobility or mentation? So for today, I'm going to highlight mobility. How do we ensure patients move safely every day? So if we think about evidence-based practice, there really are 3 prongs or 3 different concepts we want to think about. Our patient values, the best evidence, and our own clinical experience. So for mobility, we want to ensure patients move every day so they can maintain function to do what matters to them. So that's how mobility connects to patient value. We want to make sure we're going back to what matters to them so that when we do mobility and mobility interventions, we're connecting to their values and their needs. The other thing then is the best evidence. What does the research tell us? Well, the literature is very clear what the gaps are. There are systems barriers such as staffing and equipment and training. There are patient barriers such as pain and acuity. There are nursing barriers such as owning mobility or assigning it to others and hoping it'll be done. And then there are falls. We have to address falls and make sure that mobility is safe mobility, not just mobility. So the literature also provides strategies and tools for addressing those barriers. So you can see here's kind of a tool that some of our units use, and you'll recognize a lot of these elements. So we have the Johns Hopkins Mobility Scale. What is the highest level of mobility the patient's done? How can we use that to set a goal for the patient? We have our fall risk. How do we assess falls on patients to determine what interventions are needed? And then we have our equipment and needs, who and what is needed to safely mobilize the patient. So the literature provides guidance on what are the barriers to expect with our gap and what are the solutions to those barriers. And then our clinical expertise. So how do we individually, what do we know? What does my experience bring? Well, we want to think about mobility as top of practice. Who and what is needed to safely mobilize this patient? Some patients just need a family member or volunteer because all they need is somebody to socialize with them and tell them they can do this. Some patients need a little bit of support. They have some oxygen, some tubes and hoses. And for some patients, it's a safety concern. The RN needs to be with this patient because of their first time getting up, invasive tubes or lines, maybe they're clinically unstable. And then in our model, this top of practice clinical expertise model, PT and OT become our coaches. How do we at each of these buckets function at our highest level? Maybe I haven't done a hip precautions in a couple of years, so PT can give me a pointers on that. Maybe I'm a new grad and I haven't worked with patients who have dementia, so an experienced nurse can show me how to engage with these patients to create a space where they will participate in the mobility interventions. Again, that idea of top of practice and coaching that we can get to. So our safe mobility program is really divided into 4 different themes or buckets. And we use the IHI model and continuous PDSA cycles to refine these. We have a dashboard we can collect data. So, the key to any good QI project is having data to monitor. So we have a dashboard to get that data for documentation as well as mobility scores. Our mobility program is really a collaboration between nursing and therapy to address those system and individual barriers. How do we make sure the unit has what it needs to do safe mobility for patients? We have mobility tech role. This is a new role implemented at UAB in 2019. During COVID, we were able to maintain our mobility tech positions, but now that we're getting into a post-COVID world, we're looking to expand our role with new mobility techs. And then alignment. How do we make sure that mobility is really aligned with our other initiatives, such as our upright team or accountable care teams? So, all improvement is change, but not all change is improvement. How do we know that these initiatives and these projects are making a difference? We need data. So there's a snapshot of some data to show. So this was a S5 South where we piloted our mobility tech. So does the mobility tech improve mobility? Well, we implemented in January, and lo and behold, our mobility score significantly improved. And then here's a unit that's HSP3. We did not implement a mobility tech role, but we did implement the other best practices. And lo and behold, they had a significant increase and maintained an increase in safe mobility. So the data shows that we can make a change, implement mobility best practices, implement a mobility tech role, and with those changes, we can see an actual improvement. And that then provides the evidence to continue our journey. So in conclusion, evidence-based practice is really about your gap. You want to think about what is that thing that you're trying to address? How do you make a change to see if it's an improvement? I think our mobility program can highlight an EBP program. You become an exemplar. If you're interested in focusing on the 4 M's as part of your residency project, please let us know. I'll be happy to partner with you and share with you kind of the tools that we have if you're interested. And it can also be a stepping stone later if you're interested in going back to school for your DNP work. We have several DNP students assigned to our 4 M's work as well. So with that, I'm going to thank you for your time. Please reach out if you have questions or anything I can clarify.